It is my pleasure to introduce Dr. Todorovic. She's the Harold Caron Professor of Anesthesiology and Neuroscience in Virginia University. And I think she's talking on a really relevant topic, one that's concerning to many anesthesiologists, pediatric, OB, and everyone else. This is a big topic in the newspapers. It comes up when you have friends over and they're wondering what they should do with their children who may require surgery. So she's going to talk about anesthesia and the developing brain. Is there a cause for concern? Dr. Todorovic. Thank you.
Good morning. I'm so glad to be here. I would like to take a moment to thank the organizers for this unique opportunity. This is just a great honor for me to be here in a lovely city that you have. I was asked to give you a fairly brief overview of what is going on in this field at the moment. It is not going to be in depth, so hopefully we'll have some time for questions. When we started focusing on this field, it's actually a field of developmental neurotoxicity. About 15 years ago, there wasn't much really that we could go for, and it was fairly new. The field had exploded over the last 15 years, and if you're trying to understand what's going on, you would probably have to go through over 300 manuscripts that have been published since then. So needless to say, it's been looked at and studied at many different levels. I have nothing to disclose. I'm not peddling any products. I'm not benefiting from this at all. We just have NIH funding and funding from private foundations. Now, as far as pediatric anesthesia is concerned, we all agree that advances in pediatric and obstetric anesthesia had put a very high demands on anesthesia as a field, and in particular on our pediatric anesthesia colleagues. We know that the number of interventions and duration is getting to be very high, and the complexity of cases are pretty much something that we could only dream about 30 years ago. We believe that over 4 million pediatric cases are happening in the United States alone, and that number, of course, goes to be much higher when you look at the whole world population. We also understand that the number of premature births not necessarily is higher. It's usually about 10 to 12%, and it's been like that for many years, but the fact that we can keep premature infants alive and actually well is something that's rapidly developing as well. And when I was a resident, that was about 25 years ago, we actually did not even monitor the pregnancies that were younger than 25 weeks of post-conceptual age, because the thought was that there was nothing we could have done anyhow since the fetus was not viable. That is actually rapidly changing, and if you talk to neonatologists, they would tell you that fetuses as young as 20 to 21 weeks of post-conceptual age are actually viable. And when you think about these tiny beings, this is actually the photo that I got from a good friend of mine from Boston Children's Hospital, and this particular premature baby weighs less than 400 grams. Actually, they do spend a lot of time in the intensive care unit, and they travel back and forth to the OR quite frequently. And if we are going to talk about pediatric anesthesia, we really have to accept the fact that kids are not simply small adults. Now, the organ that I would like to focus your attention on today is the central nervous system and brain in particular. And what we do know is the brain in humans is not fully developed at birth. It weighs only about 300 grams. It doubles in size in 6 months, and it triples in size in 12 months. So when you think about this enormous growth that happens during relatively short time period, if you consider human lifespan to be about 80 years, then you can only imagine how many very important processes have to happen during that time and have to happen in a very organized fashion. The process that I would like to focus your attention on today is the one that we refer to as synaptogenesis, or brain growth spurt. And what does constitute synaptogenesis? This is the one that I have here for you. The most important element of that is neuronal synapse formation. And this is when neurons form these dendritic trees and multiple branches with trillions of synapses that are being sent everywhere so the meaningful circuitries could be formed. In the process of synapse formation and circuitry formation, the neurons have to migrate to their final destination. They mature and differentiate, and then they finally connect. So what we are talking about here is this very important basic circuitry formations that we rely on for the rest of our lives for our cognitive and behavioral development. Now, in humans, as I said, this process starts in the last trimester of in utero life. So as Daniel said, what we do in the last 3 months of pregnancy is very important for brain development of a fetus, and also goes on for the first 2 to 4 years of postnatal life in humans. Now, what happens during developmental synaptogenesis, and I'm not going to bore you with the basic science details, but this is something that you perhaps should recognize, that developmental neuroapoptosis is actually a normally occurring phenomenon. It's referred to as programmed cell death or physiological cell death, because this is the time when many neurons undergo very highly programmed and organized dying process if they are considered to be redundant, which means if they did not make it migrating where they need to be, they did not mature, they did not connect, they are considered redundant and thus destined to die. This process is tightly controlled because the physiology does not allow neurons to die freely like they would after trauma or massive stroke. It's a very small % of neurons that is allowed to die via this mechanism. Now, all pathologists refer to that process as neuronal suicide, and it seems somewhat dramatic, but when I explain to you what that entails, it's going to be clear why they actually called it that way, because the name says it all. When you study developmental neuroapoptosis, this happens to be our 2 photomicrographs, EM pictures, but you can find them in any neuropathology atlas. And actually, panel A shows you the very early stage of neuronal apoptosis, where you see actually clumping of the chromatin and formation of chromatin balls. It's a pretty actually obvious phenomenon. You don't have to be a pathologist to see the difference. But you can also see that nuclear envelope is intact. There is no intermixing between nucleoplasm and cytoplasm. In a late phase, you see the intermixing, and everything becomes kind of a dark mess with the formation of apoptotic bodies. But what is very important about this process is that unlike trauma or massive seizure activity or stroke, it does not initiate a massive inflammatory response. In other words, the neurons dissipate like dust and they die without dragging their neighbors down with them. So this is why it's often called neuronal suicide. Now, when you think about neuronal development, we have to understand that these 2 neurotransmitters are critically important in controlling every aspect of neuronal development. And this is major excitatory neurotransmitter glutamate and the major inhibitory neurotransmitter GABA. So when I was a junior faculty at Washington University, having known this, I started asking actually a seemingly simple question. What happens when we expose these very young neurons, when they're so dependent on communicating and having these neurotransmitters in a nice balance? What happens when we start mandling there? And the question came because at the time we were trying to understand the mechanisms of anesthesia, and as all of us know, we are still not quite sure how anesthetics work, but we have a better idea now than we did 30 years ago. And we all know that many of anesthetics that we use in our clinical practice have been shown to potentiate the major inhibitory neurotransmitter, that they are basically GABA-A agonists. You can see a lot of intravenous anesthetics that we use daily, and inhalational anesthetics, mainly volatile anesthetics, have been shown to potentiate GABA in many biological systems. Now, if you look at glutamate side of the story and you focus on NMDA subtype receptors, you can see the intravenous anesthetic ketamine that is commonly used, at least in my institution, is a very potent NMDA antagonist. And if you look at inhaled anesthetics, we published in Nature Medicine in 1999 that nitrous oxide is an NMDA antagonist, is very similar to ketamine. So is a xenon that's becoming quite popular in some parts of Europe, although very expensive anesthetic. So when you look at all these anesthetics, you realize very quickly that everything that we reach for in the OR when we practice daily anesthesia in some ways manipulate these important neurotransmitter systems that have to be nicely balanced in order for neurons to develop properly. So the question is, what happens if you expose a young brain to, let's say, isophorine, and at the time that was an anesthetic of choice that we used when I was in training, and you give it alone or you combine it with other anesthetics, which is commonly the way we practice. In this case, it was a combination with sedative dose of midazolam and nitrous oxide at 75%. And you expose the animals when they're at peak of their synaptogenesis, and in rats, this happens to be 7 days of postnatal age. So when we did that and exposed them for several hours, what we found was a few things that I'm going to discuss over the next 10 minutes or so. First, we noticed that there is a widespread neuroapoptosis that occurs in many brain regions. We noticed that when we studied memory in a dish using long-term potentiation paradigm, that it's severely impaired a month after single exposure to anesthesia. And when we studied these animals on different behavioral paradigms, what we discovered is that as they get older, their cognitive abilities were getting actually worse. So there was a gap in learning abilities. And I'll tell you a bit about all of that. So this is the picture that we got. You compare the A panel, that's a control panel. This happens to be anterior thalamus. It could be many other brain regions. And if you look at B panel, these dark dots are actually dead or dying neurons that are impregnated with silver. So you don't have to be a neuropathologist to see the difference. The difference is really massive. And these are the animals exposed to anesthesia at 7 days of age when the brain is at peak of its development. When you look at cortex, you get these bilaminar, very tightly programmed death that actually happens within a day or so after anesthesia. And actually, if you go down to the ultrastructural level, what you see is that the dying process is not any different pathologically. The dying process is exactly the same as naturally occurring apoptosis. The difference is that anesthetics push more neurons into a redundant category destined to die by this mechanism. An interesting discovery came actually when we looked at these brain regions 2 weeks post-anesthesia exposure, and this is at the time when brain is almost fully developed in rats. And what you can see is when you study neuropil is that it's in a control animal, very nice and tight, that all the profiles are tightly put together. And you can see these dark dots. I don't have a pointer, I have to apologize, but there are a lot of synaptic contacts that you can see there, meaning that this neuropil is very healthy and ready to do what it needs to do to provide us with cognitive development that we need. If you look at the panel that's labeled as experimental, you can see the massive, massive destruction of neuropil, a lot of holes, a lot of empty spaces, and not really too many synaptic contacts to talk about. Now, we asked for help from one of our pathologists who was blinded to the condition to tell us what she thought, because this is her field of study. And she actually asked us whether the animal was exposed to gasoline, whether the animal inhaled gasoline, because that's exactly the picture that you get in animals that are exposed to gasoline. Now, we also noticed two other phenomena I want to bring your attention to so you can understand some of the clinical studies that I'll talk about. And one is what we refer to as complexity of synapsing. If you look at control animal and you look at dendritic process there, you can see as many as 5 synaptic contacts ending on the same dendrite. And that tells you that the complexity is so high, and this is what we need in order for neurons to communicate in an organized fashion. It's a very complex circuitry. If you look at anesthesia-treated, it's labeled GA, general anesthesia-treated animal. Again, very frazzled, very ugly-looking neuropil, and no connectivity between nerve endings. If you look at the panel at the bottom, 2 panels at the bottom, you can see what we call redundant synapsing. Not only that you have less synapses, but the ones that you have seem to be sitting on already degenerated endings, meaning that they're completely redundant and thus not functional. So not only that you have downregulation of synaptic contacts, but you also have the ones that are left behind of barely being functional in reality. So the question after all of this morphology was then, are there any functional implications? Why do we really care? I mean, we are clinicians, we practice. What I want to know is, does it have any functional importance? So this is what this study was about. We exposed these animals to anesthesia at 7 days of age, and we let them live for up to 6 to 8 months, which is middle adulthood for rats. We followed them on many different paradigms, and these are 2 cognitive ones that are pretty commonly used, Morris-Water maze and radial arm maze. And what you can see if you look at panel A is actually the animals, and these are dark circles. Control animals get the task very fast. It's based on the fact that rats are excellent swimmers, but they hate to be in the water. So it's a great stimulation or motivator for them to actually get out of the water and get on the platform. So you can teach them within 2 days or so how to find the platform based on the visual cues. If you look at animals that are exposed to anesthesia at 7 days of age and examined at juvenile and later age, they just don't seem to get the task fast enough. So the initial feeling is that they are slow learners, but what is really interesting when they are older, at the age 131 days of old, they actually cannot learn the complex task. And that is often referred to lack of ability to learn executive tasks. And I'll get back to executive function later, so if you can just keep that in mind for now. So when FDA was quite concerned about that, and I had to testify because the first study where we were showing that was quite devastating and upsetting for a lot of folks. So FDA wanted me to testify, and I did in 2004 and 2005. And actually right after that, they decided, because they have a very large primate, non-human primate colony, they decided to investigate what happens there. And this is the study done by them. And if you look at primates that were exposed to ketamine a day, 5 days postnatally, and then followed for up to 2 years, what you see is that there is a gap in learning even in non-human primates. They use operant test battery for that. And what they notice is that these animals are slow learners, that they make a lot of mistakes, but very interestingly, they're really not even motivated to do the task, which is kind of unusual for monkeys because they work for banana pellets, and they like those banana pellets. You can train a child on the same paradigm, and that they actually are about 4 years of age, except that kids work for quarters, not for banana pellets. What about clinical studies? You've been patient enough with me to listen about animal studies, but this is really what set the stage for doing clinical studies. And the initial notion was that there's really nothing to talk about. If it was anything to be seen, we would have known that by now. And of course, this is when the work was severely attacked. By the time clinical studies started coming out, there was no doubt that there is developmental neurotoxicity induced by anesthesia in animal models. The question was how relevant that was for what we do daily in our clinical practice. So numerous epidemiological studies started coming out from about 2009 all the way to, there's another study that just came out last week. And you can see that some of the studies are showing that, yes, there is an association between early exposure to anesthesia and issues with school performance later in life. And there are some studies that are not quite sure to be showing any kind of association. So the jury is kind of out still trying to decide whether there's something to be truly concerned about or not. But one thing that comes out when you look at this little table is that two important issues. One is that duration and number of exposures really matter. Once you start going into 2, 3, and more exposures, this is when association becomes much stronger. And also, the studies that tend to be negative are coming from Europe. So I'm not really sure whether they have a different schooling system, whether their testing process is different. So that is something that needs to be looked at. Now, I'm going to take you through 3 main studies, or 4 main clinical studies that have come out since 2009, and then we can certainly talk more later. One is the study that came out in 2009 from Mayo Clinic, and in that study, that was a retrospective, very large study when they looked at over 5,000 kids. It is done in Olmsted County that is fairly uniform in terms of the fact that kids come from same type of middle class families, but at the same time they go to a couple of schools and they all go to the same hospital. So the records, school records and the hospital records could be easily obtained. They looked at hazard ratio as a predictor of learning disabilities when the difference from what kids should be doing in school as opposed to what they are doing is at least almost 2 standard deviations. So in other words is how differently they perform based on an IQ score that would predict how they should perform in school. And of course, they did adjustments as much as they could based on the large group of patients that they had. Now, when you think about what cases they focused on, and actually the majority of cases were ENT and general cases as well as orthopedics and urology, so the kids were otherwise fairly healthy, and I'll show you more about that later. Now, when they looked at what actually happens, considering that hazard ratio that I told you about, 2 things that come out really easily from this is the fact that as soon as the exposure is more than 2, 3 and plus, and the duration is more than 90 minutes. And this is cumulative duration, meaning you can have 20 minutes of CT scan today, 30 minutes of MRI scan the next day, and then you spend half an hour being intubated for a different reason and sedated. That all counts towards 90 minutes plus. That there is a high actually hazard ratio that these kids have a higher propensity of developing learning problems. And this is how the curve looks like. In Olmsted County, they recognize very early on any type of learning disability. They start testing kids from 5 years of age, and they do not quit till they are ready to go to college. So you can see in a population of kids that were not exposed to anesthesia during the first 4 years of postnatal life, that we see that about 10% or so of kids do have problems with learning disabilities. Kids who are exposed once do have a little bit of gap initially, but because this is a fantastic school system where this is recognized early and remedy programs are offered, they catch up. Kids that are exposed for multiple times never catch up, and there's as many as 30% of them that are actually struggling in school. Now, when you look at the ASA status of these kids, the initial reaction would be, well, what do you expect? These are very sick kids. You don't put them to sleep for the fun of it. They go back and forth from the OR to the ICU. They're away from their family. It's far from ideal. So, of course, ASA4 kids are going to be more affected than ASA1 kids. And what I found really interesting, if you look at more than 3 exposures, and the N is not that high, obviously, luckily we don't have that many kids that are in that category. But when you see that, you look at ASA4 category, there was not a single child that was found to have learning disabilities, despite the fact that they were considered ASA4 and were exposed for more than 3 years. So it really does not have anything to do with the ASA status of the child, or at least not as much as we thought it would. The same group went on to publish in 2012 the study looking at the same cohort of patients and looking at actually their behavioral development, and found that kids exposed to anesthesia more than a couple of times for longer than 90 minutes do have higher propensity for attention deficit and hyperactivity disorder. In many ways, this graph mimics the one that I've shown you a couple of slides back, focusing on learning disability. Now, when we travel to 2012, we look at another study. Actually, Dr. Block and his colleagues published in Anesthesiology. This study was done in Iowa. This time, they actually did not look at kids up to 4 years of age. They focused on kids up to 1 year of age. Now, they have cases that are fairly simple and fairly healthy kids. I think they all were, majority of them were ASA1, maybe a few were ASA2. And you can see these are very simple surgical procedures that they had. And now we are traveling at the time when it was closer to what we are using now anesthesia-wise, because if you remember, Mayo Clinic was in 1970s, so some of the anesthetics we do not use anymore. And they looked at academic achievement score tests that are Iowa-based tests that they're very familiar with. These two panels actually are pretty much the same population of kids, except the one to your left is focuses on kids that had surgery up to 12 hours, and I don't know how you can do any of orchopexis or inguinal hernias that take 12 hours, but, you know, we've seen it all, I guess. Be that as it may, and the other one is a little more compressed, so they stayed with up to 4 hours of anesthesia. And, you know, we can criticize that and go back and forth, but what really sticks out, is, if you look at that, is that there is a direct linear correlation between the duration of exposure to general anesthesia and propensity for having learning disabilities. What was really interesting for me, it's kind of buried in the text and you have to read between the lines, is actually that in Iowa, the population of kids that are in the bottom 5th percentile is about 5%. In the group of kids exposed to anesthesia before the age of 1, about 12% of them were in the bottom 5th percentile in academic achievement. So I don't know whether anybody wants his or her child to be in the bottom 5th percentile, but it looks like that it was almost doubled. Now, Dr. Ng actually pointed at something that I thought was very interesting. If you're going to study these types of learning disabilities, you really have to chisel it out. You have to really look for it. You have to be very specific. It's not a gunshot approach, and it's not going to stare you in the face. So this is what they did. They looked at Australian cohort of patients. It was a fairly large cohort of patients, and what they found is that when they looked at specific domains in language and cognition, they actually found that adjusted risk ratio was as high as almost 3. So that's pretty substantial. Now, what about narcotics? We use them all the time, and I hear that people suggest that maybe we should use more narcotics with everything that we know, because as you know, they really do not act through GABA or NMDA, although very high doses of narcotics have been shown to have an effect on NMDA receptors. But the ones that we use in daily clinical practice most likely just affect opioid receptors, in particular mu receptors. So the question is, can we use the narcotics as opposed to general anesthetics? And what we did in a very early study is we used guinea pigs to study the effects of anesthetics that we were interested in, because guinea pigs, their development is in utero. So you work with a pregnant mom who is 1.5 kilos. So you can do everything that you normally do in the OR. You can intubate, mechanically ventilate, put an A-line, put a central line, and so on. And we wanted to know how fetuses or whether fetuses were affected. But we used fentanyl as a sham control, because you can't really do anything that invasive with a pregnant mother who is not somewhat anesthetized. And what we found when we kept everything, I mean, you can see all of these parameters were kept within normal limits. We didn't allow anything to wander outside of a normal range for a pregnant guinea pig, which is basically how we practice in clinical setting. And despite keeping everything tight and neat, first of all, we saw that anesthetics still do cause quite a bit of neuroapoptosis. But when you look at fentanyl, there was a slight increase in neuroapoptosis, but not enough to be called significant. And similar findings were shown with morphine a few years later. So what about humans? Now, this is the last study I want to show you. It's the study that was published in 2011 in Pain, and was actually done in Europe, in Holland. And what I find really interesting, this is not a retrospective study. That is a prospective study where they looked at neonates that were exposed to morphine in the intensive care unit. They were 150 of them. They were all mechanically ventilated, so there's no healthy neonate here. All mechanically ventilated. They were followed up for 5 years afterwards, and you can see what tests were they focused on. Now, this is how the study was conducted. They started with 150 kids. They went on to have 125 for a follow-up, and then they divided them in 2 arms. One arm got a loading dose of morphine that was followed up by a continuous infusion of morphine. And if the neonate, if the nurse or the physician felt that the neonate needed more, if they were doing something painful, they were allowed to give a breakthrough dose of morphine. The other arm, and I'm not sure how they got this approved, but they did, kids were mechanically ventilated for 30 days. They gave them initial bolus of morphine, followed by continuous infusion of saline for 30 days. They're all mechanically ventilated neonates. They were also allowed to give them morphine for breakthrough pain when the providers felt that it was painful, whatever they were doing. Now, interesting thing is that the amount of morphine that was given for breakthrough pain in these 2 groups was not significantly different, despite the fact that the control group was given only continuous infusion of saline. They looked at a variety of paradigms over the course of 5 years, and what I thought was very interesting, they looked at the IQ test score as well, and they concluded that although at the end, initially it was found to be a significant difference in these 2 groups of neonates, once exposed to morphine continuously and once exposed to saline continuously, but they found that there was about 10 units of IQ score difference between these 2 groups, morphine kids doing slightly worse. When they corrected for everything that they could think of, it was not significant anymore. But when you think about it, it really matters where you are at when you start losing your 10 points. I don't want to lose any points of my IQ, but 10 points was considered not to be significant. So I'll just leave it up to you to decide. But what I thought was really interesting is that when they looked at subdomains of the IQ tests, they discovered that these morphine kids consistently performed worse on the visual analysis portion of the IQ test. And from what I gather, visual analysis portion of the IQ test is the best predictor how higher neurocognitive functions will be developed. In other words, the higher executive functions. And if you remember our rat study from many years ago, this is where we actually noticed that the gap was widening as the animal was getting older, and the gap was getting worse as the tasks got more complex. So you're basically creating kids that may have problems with the higher cognitive functions and, more importantly, with the higher executive functions. So just to finish this, I want to show you, this is the email that I got from a chair of neurology department at Virginia Commonwealth University, and this is what he said. Many years ago, Thomas Kuhn wrote a famous book, The Structure of Scientific Revolutions. Among other things, he invented the term paradigm shift that is now part of our vocabulary. He described the three phases of a paradigm shift. First, it is ridiculed, then it is resisted, finally, it is considered to be self-evident. At the time, that was in 2011, he said, so you figured out where you are in the blame for this paradigm shift, probably past 1 and the late stage of 2. Interestingly, 2 years later, it looks like the European colleagues got together, and one of my colleagues from Geneva, who is a pediatric cardiac anesthesiologist, was present, and he knew actually that I was about the Thomas Kuhn's book. So he said that they got together, and that pediatric anesthetic neurotoxicity is widely considered by actively exercising pediatric anesthesiologists as one of the most important current issues in our practice. So maybe we are approaching the self-evident stage. I'm not sure about that. It's still being quite challenged, but the field is rapidly evolving, so we'll have to stay tuned. And finally, you all probably have heard of Smart Thoughts, which is the organization that was put together. The initiation came from the FDA. As I told you, FDA was very concerned, and I was chased by FDA for quite many years. And then they teamed up with the International Anesthesia Research Society because they cannot do any fundraising as a federal institution. So between FDA and International Anesthesia Research Society, they partnered to form Smart Thoughts that actually is tasked with multiple issues that need to be addressed, and also is hoping to provide funding for investigators, talented investigators who look at that. And then finally, just to thank the folks who did a lot of work for that and for the funding that I have to run my lab. Thank you so much.
So I'd like to ask the audience to come up to the microphones and ask any questions.
Good morning, Philippe Richebet from University of Montreal. Thank you for your very nice talk. It's always interesting to listen to you. I have one question. We know that the problem that you have described are related to the dose, to the number of exposure, to the time of exposure to anesthesia. But as you said also, we don't have choice to do anesthesia in these kids. So do you know any kind of preventive or preventative strategies that we could use every day in our daily practice to try to avoid or to decrease this kind of phenomenon?
Thank you. That's a very good question. Well, I didn't have enough time to get into that. Obviously, as soon as we recognized that it's neuroapoptosis in nature, we all kind of flocked over different neuroapoptotic pathways trying to block them, because once the caspase-3 gets activated, cell is committed to die, and it's too late. So there are many neuroprotective strategies that have been published over the last 15 years looking exactly at that possibility. Some of them were beta-estradiol, lithium, coating the head, melatonin, pramipexole, list goes on and on. We've seen some studies with xenon putting in the mix that seemingly helps, which mechanistically is kind of hard to understand. Dexmedetomidine is another one that seems to be pushed out as potentially being protective when combined with these anesthetics. So there's a study now that it is conceived but not really approved by the FDA as of yet, where they're trying to combine dexmedetomidine and remifentanil to see whether that's an option. I'm a little concerned that this is not a full anesthetic, so that we may be going to another extreme, but also possibility of combining dexmedetomidine and sevoflurane to see whether there is going to be any benefit with that combination. So there are many attempts to actually figure out what would work potentially. None of them have been clinically applied as far as I know. But short of that, I think I can tell you two things. One is, based on the experimental work that we've done, volatile anesthetics seem to be simply evil when it comes to developing brain. Not only that they smell bad, but they're really bad for your brain. And a colleague of mine calls them chemical cleaners. And really they are. I don't know whether you've tried, but you can remove any type of stain with isoflurane or sevoflurane. But they are not only chemical cleaners, they are brain cleaners. They really do cause a lot of damage. So maybe intravenous anesthetics, although we have plenty of evidence that they are just as bad. but the duration is critically important. If you can cut it back and go, as quick as you can, this is the key, and that's what we are trying to do in the States right now. Whether you wait or not, you may not have that option, as you said, but can you do it in 30 minutes as opposed to an hour and a half? In my institution, CT scan takes 2 hours, 3 hours sometimes. By the time the kid is put to sleep, the IV is initiated, we go from the induction room to the CT room and back. I mean, these are 30, 40-minute scans that take 3 hours of anesthesia.
Hi, good morning. I'm Vandana from PEI. I just have a question about your slide on the study which was done by Rizzi on guinea pigs. And they were using fentanyl 30 milligram per kg, which is like quite significantly, very like super high dose. So should we imply the result of the study to what we do in our clinical practice?
When you talk about doses in animals versus humans, you really have to be very careful because all you can do is go for equipotent doses. Species are very different. I'll give you an example. If you give propofol to rats, 1 to 2 milligrams per kilo doesn't do the trick, and even 10 IP doesn't do the trick. So these are all equipotent doses. I can tell you that mother was barely asleep with that dose of fentanyl. So the best that you can do is go for what's clinically applicable in a setting that you're working in. But when you start working with different species, you really have to look that up and make sure that you are comparing apples to apples as opposed to apples to oranges. So these are not high doses of fentanyl in guinea pigs.
Okay, thank you.
Thank you.
Morning. Thanks for the talk. Mohammed Ismail from London, Ontario, Western University. Did we study babies for IV drug user moms? And another question, premature babies, are they more liable to have complications from anesthesia compared to full-term babies?
You mean complications as far as developmental neurotoxicity? The work that's been done in utero, there is some work that's coming out now where they looked at the effects of sevoflurane, desflurane, and isoflurane when the exposure occurred in utero. And they're showing that, at least in animal studies, that there is a problem in cognitive development. If you remember, Mayo Clinic did look at C-sections done via epidural versus general anesthesia, and they found no difference in 2 cohorts of patients. So if you talk about very short exposure that occurs from the time mother goes to sleep till the infant is out, the neonate is out, that doesn't seem to have any effect. If you're talking about abuse, that's a different story. And based on the animal studies, there should be a problem. There was a study in 1986, I have to tell you, where pregnant rats were exposed to halothane. Not only that offspring of that pregnant dam were having problems with learning, but the offspring of the offspring that were never exposed to anesthesia had problems with learning. So it's a pretty intense problem that you could see. As far as premature babies, if you think about what's happening during that time, you would think that they would be more prone to that particular problem because they are also exposed for a very long time. You're talking days, and they go back and forth from the OR to the ICU to have this fixed and that CT scan and that MRI scan. But when folks try to stratify that based on age up to 4 years of age, the difference was not that tremendously significant. So it's hard to know. Also, different brain regions develop at the different time points, so you can have some of them to be much more vulnerable last trimester of in utero life, and others, more importantly, affected later.
Hi, Richard Robinson McGill. If you have to use gases, is it worth using the BIS? For example, if you run a REMI infusion, you need half a Mac of the gas to give you a BIS of 40 to 60. So you're limiting the amount of gas you're giving to anybody by running a REMI infusion and monitoring the BIS. So is it worth putting a BIS? It's $60 each, but is it worth putting BIS on if you have to use a gas?
Yeah, I actually think that that's a very good idea, and I think that's why people are starting with. How would you do it, though? You would give it. You don't have an IV at that point, do you? How would you give your narcotics? Do you put an IV?
I don't do pediatrics. I do adults.
Okay.
I use Remy propofol always, but
Right.
For a kid, if you're going to gas them down, which you have to usually to put the IV in, would you put the BIS on and then run Remy infusion and then titrate down your gas?
I think that's
easy to keep your BIS at 50.
Yeah. I think that's a great idea.
Dose of anesthetic, but you have to get
I think that's a good idea. Or you can try to do dexmedetomidine, which is what they're trying to do with this THELAMUS study that's starting right now. That's what they're proposing. Start with the inhaled anesthetic and then put an IV and continue with dexmedetomidine while keeping this. Although what they're proposing is to actually get rid of SIBO soon after dexmedetomidine is infused and then combined with remifentanil, which is basically what you're suggesting.
Well, in adults, if you use Remy, you can get down to half the dose of a gas. Or in my experience, when I put a BIS on, if I ever use an inhalation.
I can tell you, talking about combining anesthetics, what I was shocked to see when I was doing these experiments many years ago is that as soon as I started combining anesthetics, which is the way we practice, things got out of control and got worse. Give you an example. Isoforin alone at 0.75% did not cause as much damage as isoforin plus nitrous oxide, for example. As soon as you start putting something else, it gets exponentially more toxic, so we call it synergistic effect. Now, xenon is proving us differently, and dexmedetomidine is proving us differently. So there are ways to combine anesthetics that actually not have potentiation of the effect. Yeah, that's a very good idea, and that's what THELAMUS study is doing right now.
I'm just interested in the audience. For those who do pediatrics, how many are actually speaking to the families and saying that this may be an issue? Is anybody raising this as part of consent or part of a risk? So of those who do pediatrics, can you just put up your hand because I want to know how many are doing pediatrics. How many people would say, we don't mention this at all? How many mention it a bit if the parents ask or would mention it as routine? So about 50-50. I'm just interested.
Yeah,
another question?
Hi, Gregory Kralchuk from Ottawa. I'm not a pediatric anesthesiologist, so I apologize if it might sound ignorant, but I'm proposing a paradigm shift. We use volatiles and propofol to induce unconsciousness. All the other elements of anesthesia could be done with other things. The analgesia with opioids, as you have shown, with spinal, with regional. And so the question is, do we need to take care of or address awareness and consciousness in 20-week-old infants? In other words, do we need to expose them to the volatiles, the propofol, and is that a line of thinking that's being experimented? Because it seems to me, if I had a 20-year-old and if I were a pediatric anesthesiologist, you could run it on high-dose opioids and rocuronium, essentially. You could do a block, or you could do a spinal. Do we need to take care of awareness, which is why we're using volatiles and propofol?
Yeah, thank you. That's an interesting point. I think that's what THELAMUS study is trying to address. Are we going too far now to another extreme? When the study our studies were coming out, I had a colleague who started practicing in 1930s, and he actually intubated the first neonate with a Foley catheter. We've come a long way from then. But what he said is, I remember actually doing just what you said. Actually, they used to just give succinylcholine to these very tiny neonates and just intubate them and wouldn't do anything else. Now, if you remember, there was a study from Dr. Anand that came out in New England Journal of Medicine in the 80s. And it was based on, I think, 8 or 9 neonates in the NICU. And they had subjective assessment of the nurses taking care of these kids to say that they suffer and this is incredible and we really have to do something about it. And this is when we went all the way to, when I was in training, we would have neonates on propofol drip for days, midazolam drip for days, because we didn't want them to remember or to have any problems with that. So, happy medium is probably somewhere in the middle, as always is. Do we just do succinylcholine and intubate them? I mean, you saw this European study. They used saline for a month. And these kids were mechanically ventilated, and these kids did better than kids who had morphine. And actually, they used the same amount of morphine for breakthrough. You would think that it wouldn't be the case. So it's something to think about. You know, do we really need to put this, you know, as was suggested, can we titrate that as opposed to just using milligram per kilo dose? I'm not sure, but I hope the THALAMUS study, this is what they're doing. They're putting caudal and doing dexmedetomidine and remifentanil to see whether there is a problem. But there are cases when caudal is not enough, as you know. So we'll have to see. So, yeah.
So I have time for one short question because we're running out of time here. So.
Good morning. Thanks for your talk. I'm Simon White. I'm a pediatric anesthesiologist in Vancouver. So my short question was actually about the second period of synaptogenesis that you see in teenage children. But before I ask that, somebody mentioned about not being able to get IVs into children. And so just to say that I think that's a myth that we should dispel. And in our unit, we use total intravenous anesthesia substantially. I can look at my own logbook, and 90% of the cases I put an IV in before the kid goes to sleep. It requires a change in culture, and not just me deciding that that's what I want to do, but I would hate people to think that it's, in this day and age, not possible to do. My question is about synaptogenesis in teenagers, because although a lot of the work has been focused on the neonatal and the early childhood, we do have this second phase of synaptogenesis in early teenage life, and I'm sure many members of the audience who don't spend their days anesthetizing neonates do spend their days anesthetizing that population more readily. And I just wondered whether you had any comment on any of this body of work and whether it extends to that subpopulation as well.
Yeah, that's an excellent question. I have to tell you, it's an excellent question because, as you know, initial work was done in postnatal day 7 rodents, because this is when they were most vulnerable for what we were looking at, which was developmental neuroapoptosis. When we exposed them at postnatal day 15 to 20, which is adolescence for rats, what we discovered is that actually there's no neuroapoptosis, but what you see is massive development and retention of synapses that otherwise should have been pruned. So you go from having downregulation of synaptic contacts to this out of control, massive either formation or lack of pruning of synapses. So the question was, is that good? And the answer is most likely not. And that could lead to some of the hyperactivity, attention deficit problems, or inability to do higher cognitive tasks. Another interesting thing, and that's been, the first one is published, so you can look it up. But the second one is what we've been doing over the last couple of months or so. Another thing that anesthetics do hurt quite a bit is axon pruning, the formation of these nice circuitries that I told you about. And we are actually seeing that the response to anesthetics, in this case is ketamine, when they are given ketamine at 7 days of age, is very different than when they are given later. And you can see actually that pruning, again, you have nice pruning that happens initially. When you expose them at adolescent age, the pruning stops from happening. So you have all this sprouting that goes everywhere, and it shouldn't be there, which actually can be a problem for their learning. So I don't know yet. We haven't done that yet. There are some clinical studies looking at 10-year-olds, and they found that there's no cognitive problem, but there are some type of sensory motor issues that affect the way how these kids process the information.
So we're going to wrap it up there. Thank you very much.
Thank you.
Thank you, Dr. Sturgeon. Thank you so much.